Welcome to the deep dive. Today we're taking a really crucial look at something sensitive, often hidden, the crisis intervention system right here in Southeast Michigan.
Yeah, and we're not just, looking at policy papers. We're tracing the path of failure based on one person's direct, pretty harrowing experience during the pandemic stress back in 2021.
Exactly. Our mission here is to connect that very local personal breakdown, the search for a crisis intervention officer that just wasn't there, to the bigger picture.
Right, the massive structural issues and how things are governed, how they're funded, especially with Oakland Community Health Network, OCHN, and accountability.
The sources you shared, they paint a picture of frustration, don't they? Financial reports, census data, and these really tough personal notes detailing a traumatic time.
Mm-hmm.
So we're trying to unpack the key question.
Yeah.
Why are these vital resources spread so thin? And why did this supposed fix, this regional co-response program, just create, a different kind of bureaucratic mess?
It's a fair question. And look, before we dive into the gaps, let's just quickly acknowledge the resources that are generally available.
Okay.
If you're listening in Southeast Michigan, you've got the WIHN Crisis Hotline. That's 1-800-241-4949. And, of course, the National 988 Suicide and Crisis Lifeline.
Right. Standard numbers.
And there are walk-in options, too, like Team Wellness CSU for immediate care, but that's not really the focus here.
No, the focus from your sources is that street-level response, the core program, Co-Response Community Outreach, launched August 2021. This was meant to be the solution, right?
Supposedly. It's an interesting setup, a partnership between 3 police departments, Birmingham, Auburn Hills, and Bloomfield Township.
Okay.
And the specialist, the mental health clinician, isn't a cop. They're employed by OCHN, that regional body we mentioned.
So the idea is the clinician steps in for de-escalation, does an on-site assessment, connects people to services,
Right.
trying to avoid arrests or unnecessary ER trips, clinical support right on the scene.
Exactly. But here's the crucial structural point, the tension.
Yeah.
That clinician. They have zero legal authority to make someone go for treatment involuntarily. None.
Yeah.
That power, the ability to, compel someone, that rests entirely with the police officer who's also there. The assessment is clinical, sure, but the action, the power, it's all law enforcement.
Okay, that's a really important distinction. It sounds good on paper, but let's talk about the funding, because that gets complicated, especially crossing political lines.
It really does. Your source notes mention confusion, right? About how U.S. Rep. Stevens and MI11 got federal funds when the person experiencing this was in the 12th district next door.
Yeah, how does that work?
Well, it shows how local cooperation can sometimes, work around rigid federal lines. Rep. Stevens secured $335,000 in community project funding. Good stuff.
But only for the parts of the partnership in her district.
Precisely, Birmingham and Auburn Hills.
So how does the listeners' community outside that funding zone get any benefit?
Clever local agreements. The listener city pays for an interlocal deal to share dispatch services with Birmingham. So essentially, they're buying access to the core clinician if they're available. It's a workaround.
Okay, that makes sense. But it also points to another issue your source brought of a friend saying the community is leaving money on the table.
Right. And that's a sharp economic critique. Because these communities, they're often paying their share for core, mostly out of their general fund, local tax dollars. Instead of aggressively chasing down other available grant money, federal DOJ grants, Oakland County ARPA funds, that money is out there, or was.
So they're taking the easier path financially, maybe? Just paying out of pocket?
It seems like it. Opting for, let's say, administrative simplicity over maximizing those external funds. And that choice, that operational inefficiency, well, it leads straight back to that core failure you experienced.
And this is where it gets incredibly personal. That moment in your notes, calling for help, needing that specialist, and being told the clinician won't be available until tomorrow.
That one sentence. It just reveals the fundamental flaw in the program's initial design. Back in 2021, this whole setup, serving over 100,000 people across 4 communities, relied on one single clinician employed by OCHN, just one person. They simply couldn't be a 247 resource. It wasn't possible.
Let's try to quantify that. We looked at some conservative numbers. Even if you assume only, say, 2% of all police calls are mental health related.
Which is probably low, honestly.
Probably. But even then, those 4 communities together generate minimum, something like 4.2 emergency mental health calls every single day.
And one person working a standard 40-hour week, they're swamped instantly. The fact you were told tomorrow, That proves they were on a fixed schedule, a static block
I
schedule.
mean, what exactly?
Meaning they weren't free because they were already booked,
Yeah.
pre-scheduled for follow-ups, proactive case management, that kind of thing, often dedicating a whole day to one city.
So, my crisis, happening right now, 5 minutes away. It gets pushed to tomorrow's list because the clinician is scheduled 30 minutes away in another town doing routine follow-ups.
That's the functional reality of that schedule. It means on any given day, that clinician was effectively unavailable to 75% of the population they were supposed to serve.
That just seems structurally unsound. If the police are partly funding this to save their officers time, why accept a schedule that makes the resource unavailable so often? Okay, optimize the driving for the scheduled stuff.
Yes, and the time saved doing that may be 60, maybe 90 minutes a day. That's not just saving gas. That saved time creates the availability needed for a sudden reactive 9/11 crisis.
Instead of being locked into a rigid city-by-city block schedule that inherently wastes time and availability.
Precisely. The bureaucratic schedule itself becomes the bottleneck.
Okay, let's shift gears slightly but connect the dots. Your notes also detail that really difficult hospital stay in December 2021, feeling like the staff were just absent on the psychiatric ward.
Yeah, and what's really sobering is realizing that the core clinician being stretched impossibly thin and the absent staff on that psych ward, they were symptoms of the exact same problem.
The system-wide collapse during the Delta variant surge.
Exactly. December 2021, it was a chronic issue hitting a crisis point. People think about ICUs being full, but the hospital system, according to the sources, had to temporarily close 180 beds. That's like 5% of their capacity.
Not because the beds were physically full,
But because there weren't enough staff. Critical shortages, nurses, techs, they just didn't have the people.
And you mentioned the specialized staff.
That's the kicker. Psych nurses, psych techs, the very people needed on that ward were being redeployed, pulled off their units to help in the overflowing COVID ICUs.
So the ward felt not busy, as you noted, because its actual capacity had been deliberately slashed due to staffing shortages elsewhere.
Correct. And the staff who told you the system was shitty even before the pandemic, they weren't wrong.
No, this wasn't just a COVID problem.
Not at all. It's built on years of chronic underfunding. Remember that massive 60% cut to general fund revenues back around 2014-15? Plus, state reports consistently show Michigan ranks third worst in the nation for shortages of mental health care professionals. It's a long-term crisis.
Which brings us back to OCHN, the administrator managing the money.
Right. This public body, the PIHP, handles a huge amount of money, $300 to $500 million a year, mostly Medicaid per month payments.
A lot of money flowing through. But where does it actually end up? Your sources pointed to something pretty cynical.
Yeah, the financials. OCHN reported a $15.2 million net revenue, basically, a surplus in fiscal year 2022 alone.
15 million surplus. So what happens to that money? Does it go back to help services?
Well, this is where the cynicism comes in. That surplus didn't immediately flow back into, say, hiring more clinicians or boosting hospital staff. It went into what's called the Internal Service Fund, the ISF.
Which is?
Think of it as a giant reserve fund, a bureaucratic savings account, essentially, a risk reserve.
So the money is being successfully managed and held at the administrative level.
While the direct service level, the psych wards needing staff, the core program needing more than one clinician remains critically under-resourced. The bureaucracy protects its reserves while the front lines struggle.
That's stark. And if we connect that financial picture to patient vulnerability, you brought up something called Simpson's paradox.
Yes, it's a way to think about the risk here. Look at the demographics within the core partnership. You've got really affluent suburbs, median incomes way up there, 140K, 175K, very low poverty.
Okay.
Then you have Auburn Hills, median income closer to 78K, poverty over 11%. Much higher need statistically.
So the paradox is?
The paradox is, if CORE reports a great overall success rate, let's say 90% diversion across all 4 communities, that combined number can completely hide failure in the place with the highest need, like Auburn Hills.
Because the high success in the wealthy, stable areas averages out the potential failures in the area with more poverty and likely more complex cases.
Exactly. A single aggregated statistic masks a reality on the ground. It proves that a one-size-fits-all resource model doesn't work well when the needs are so different. You need to break down the data by city, by income level, to see if it's truly working everywhere. Auburn Hills probably needs its own dedicated clinician, not just a fraction of one.
And what about the police perspective in all this? We shouldn't just assume indifference. There are pressures on them too, right?
Yeah, absolutely. You have to look at the incentives, like in, Freakonomics. For the police, the motivation is largely time savings and liability reduction.
Get the situation resolved quickly and safely and get back on patrol.
That's the primary goal. An officer's job is patrol, response, maintaining the budget. Mental health calls, from that perspective, can be seen as a significant drain on time and resources.
So they use the process, making an arrest for a minor offense, or, more often, transporting the person to the hospital ER as a way to hand off the problem.
It acts like an iron curtain, yeah.
Right.
It allows them to clear the scene quickly, transfer the burden, the hot potato, as you called it, onto the hospital system. It protects patrol hours, protects the police budget.
Which, speaking of the hospital system, you noted the rebranding. Beaumont becoming Corewell Health.
Yeah, that merger with Spectrum Health in 2022 and the name change. It feels like a pretty calculated move, an attempt to shed the baggage associated with the Beaumont name pre-merger.
Baggage like?
Like the very things you experience, widely reported staffing crises, big operating losses, leadership controversies. A fresh start, brand-wise.
Okay, so pulling all these threads together, what's the fundamental structural failure we've uncovered here?
I think it's this false dichotomy the system operates under. This unspoken belief that the city's long-term needs, like public safety or budgets, are somehow separate from or even opposed to the immediate mental health needs of the people living there.
But they're not separate at all, are they?
Not in reality. The most effective long-term public safety strategy is providing immediate, effective mental health intervention. It pays off down the road.
How so?
By reducing those high-frequency 911 callers, the people cycling through crisis after crisis. That saves police thousands of hours, potentially avoids costly lawsuits. It's preventative.
But instead, the system, as it was structured, treats the person in crisis almost like a logistical problem.
It uses the citizen as a cost-saving proxy in a way. It prioritizes the bureaucracy schedule, making your urgent crisis a tomorrow appointment over the immediate human need.
Turning that urgent need into a data point, a successful diversion from jail, log for the statistics, even if the actual care received is delayed or inadequate.
That's the tension we've traced. The administration, like OCHN, successfully protects its budget, its reserves. While the frontline workers, that single core clinician, the understaffed hospital teams are left managing the human fallout from that chronic underfunding.
So let's leave the listener with a final thought. What does this mean for you, the taxpayer, the resident?
Well, think about the real cost of this failure. The money needed now for adequate staffing, for maybe 2 or 3 core clinicians instead of 1, for better hospital support. Seems like a lot, maybe.
But compared to what?
Compared to the long-term risk of systemic failure. A major tragedy that could have been prevented, a massive lawsuit against the city or the health network, the erosion of public trust, those things cost vastly more.
And there's a direct financial link, isn't there?
Absolutely. When a city looks like it can't manage its core responsibilities, when it seems prone to these kinds of systemic failures, its overall risk profile goes up in the eyes of financial markets.
Which affects its ability to borrow money.
Precisely. It can directly impact the city's credit rating, which means higher borrowing costs, higher interest rates on municipal bonds needed for roads, schools, everything.
So investing properly in mental health services isn't just compassionate.
It's arguably the cheapest, smartest form of long-term risk insurance a city can buy. It protects residents, and ultimately it protects the budget, too.
That really puts it in perspective. Thank you. That was a deep dive. And thank you for listening.